Good evening, everyone. We will start the webinar in 2 minutes. Good evening, everyone, and thank you for joining us. My name is Helen Taguri, and I'm the Manager of Patient Programs at Crohn's and Colitis Canada. I'm very pleased to have the opportunity to moderate tonight's webinar and to learn more from our expert speakers. Tonight we have Dr. Vivian Wong and Dr. Cynthia Seow. Tonight's education webinar is Fertility and Pregnancy in IBD and is hosted by Crohn's and Colitis Canada. Please note that a link to a recording of tonight's webinar will be emailed to you after the event for future viewing. So for those of you who are new to webinars, I'll quickly run through the logistics and go over how you can ask questions. Right now, all of our participants are automatically muted so that everyone can hear the presentation and we can capture this webinar recording without audio interference. If you would like to ask a question at any point during the webinar, you can type it into the chat box. Simply look at the right side of your screen and you should see a questions field. Simply type in your question into this box at any time throughout the webinar and we'll make note of it. And following our speaker presentations, we will take time for Q&A and we'll do our best to try and get to as many questions as possible. Also, if you're experiencing any technical difficulties, you can type these problems into the chat box and we'll follow up with you directly. Also, please note, if you are having trouble hearing the speakers, it may be your computer's audio settings. So try calling in with the phone number provided using a mobile or landline phone. Great, we are ready to get started. But first, a little bit of background about Crohn's and Colitis Canada. Crohn's and Colitis Canada was established in 1974 by a group of concerned parents of children with Crohn's disease and ulcerative colitis. We are a national charity with more than 65,000 supporters and 80 volunteer groups and chapters across the country. Our promise is to find a cure for Crohn's disease and ulcerative colitis and to improve the lives of children and adults affected by these diseases. We want the general public to be aware of these chronic diseases and the toll it takes on the nearly 250,000 Canadians living with Crohn's and colitis. Crohn's and Colitis Canada has funded over $120 million in research to date. That makes us one of the largest funders of Crohn's and colitis research in the world. Tonight's webinar is part of Crohn's and Colitis Canada's online education programs. Other online education programs include our Ask the Expert Facebook live events and other digital and print resources that can be found on our website at crohnsandcolitis.ca/learn. Other patient programs include the Go Here Washroom Access Program, the Gutsy Peer Support Program, Camp Got to Go, and the IBD Scholarship. If you'd like more information, please visit our website at crohnsandcolitis.ca/learn or email us at learn@crohnsandcolitiscanada.ca. Now, to begin our presentation, I would like to introduce tonight's speakers, Dr. Vivian Wong and Cynthia Seow. Dr. Wong is an assistant professor in the Division of Gastroenterology at Mount Sinai Hospital at the University of Toronto and is an adjunct professor in the Division of Gastroenterology at University of Alberta. Dr. Wong developed the Preconception and Pregnancy in IBD clinical research program in 2013 to study the complex relationship between pregnancy and IBD and the effects of IBD and IBD treatments on maternal and neonatal offspring outcomes in order to find ways to optimize the management of IBD during pregnancy. Dr. Wong is currently implementing the clinical research program at Mount Sinai Hospital in Toronto, Ontario. Our other speaker for this evening is Dr. Cynthia Seow. She's an associate professor in the Division of Gastroenterology and Department of Medicine and Community Health Sciences at the University of Calgary in Alberta. Dr. Seow's specialties include maternal and fetal outcomes in IBD and optimization of biologic therapies in IBD. She established the University of Calgary's IBD Pregnancy Clinic and Research Registry in 2013, which provides preconception counseling and follow-up care for pregnant women living with Crohn's or colitis. So now I hand it over to our speakers.
Thank you for the invitation and the introductions, and thank you to all who are joining us today on the webinar. I will be giving a brief overview and introduction of fertility and pregnancy in inflammatory bowel disease. These are my disclosures for sources of support and research support. So just to start off with, I just briefly give an overview of inflammatory bowel disease, or IBD. This includes the spectrum of inflammatory disorders of the intestines and can be limited to the large colon, as shown on the right, and this is diagnosed as ulcerative colitis, or UC. Crohn's disease is another type of inflammatory bowel disease, and Crohn's disease can affect anywhere from the gum down to the bum. And it can be characterized as well by patients having perianal disease in the form of fistulas and/or abscesses. And it's important to distinguish between these two because it may affect your delivery methods. For people who have characteristics of both ulcerative colitis and Crohn's disease, it will be diagnosed as indeterminate colitis, or IBD unclassified. It's important to understand which type of IBD you have. As mentioned, it could affect fertility and/or delivery methods. Back up. IBD is diagnosed at all ages, from young children and infants all the way up to the elderly. However, in many of the research studies done by Canadian researchers, you will see that most people are diagnosed in their young ages, so between 20 to 29 years of age is the highest new diagnosis of IBD. And that's important to understand because IBD currently does not have a cure. So if you've been diagnosed with IBD, you will be living with it during the time that you may be considering starting a family and having pregnancies. Sorry about my rapid forwarding. So IBD is treated by various treatment strategies, which include medications and sometimes surgeries. So the old concept, or still used now, is called the pyramid of treatment, whereby the patient is started on a medication, and if they continue to flare while on that medication, then they'll be escalated to other medications such as biologic therapies. However, in some situations, patients may need to start immunosuppressants or biologics early in the disease course because of their disease severity and/or the disease type. So now on to preconception and pregnancy planning. So many of the questions people ask is whether or not IBD can affect their ability to become pregnant. And so when we talk about the word fertility, we are talking about the ability to become pregnant. We know that women with IBD in general have the same fertility as women without IBD. There are two situations, however, that can lower fertility in IBD. The first being if you have active IBD, and the second situation is if you have the ileal pouch anal anastomosis, or J-pouch surgery. And I'll now go into a little bit more detail about those two situations. So when someone has active IBD in the preconception, so before pregnancy time period, it can make it harder to become pregnant. It's partly because of the inflammatory burden, and also potentially because the mother or the potential mother is not eating enough, not getting enough nutrition. Active IBD can also increase the risk of miscarriage, and oftentimes because one may not realize that one's pregnant early on, we do believe sometimes that active IBD is you have become pregnant, but you may have an early pregnancy loss. And therefore, we do recommend that if you are considering pregnancy, that you try to wait until your IBD is in remission and you are on stable medications that can be continued during pregnancy before you try to become pregnant. And the other situation that I mentioned was if you had that certain type of surgery. So in some cases, a woman with ulcerative colitis may require a colectomy, so that's removal of the colon. And in that situation, they may opt to have an internal J pouch created from the small bowel. This may have potential risk of damage to the fallopian tubes, and potentially after the surgery may have scarring or adhesions that can block the fallopian tubes. And that is one of the reasons that this type of surgery may reduce the chances of becoming pregnant. If you have had one of these surgeries and you're finding it hard to become pregnant, you should speak to your gynecologist and fertility specialist, as one of the options is to have in vitro fertilization. If you think at some point or you've been told that you may require a colectomy, one of the options is to speak with your gastroenterologist and your surgeon before you have the surgery. And then in that case, they may opt to give you the colectomy and remove the sick colon and give you a temporary ileostomy, as shown in this cartoon. And then they would bring you back after you have completed your family and had your pregnancies to create the internal J pouch. So it's very important to speak with your gastroenterologist and your surgeons. So here, this is a preconception checklist that we recommend so that you understand whether you are ready to have a baby. First, we recommend that you check your overall health status. So ensure you're taking your prenatal vitamins. Stop substance use if you're smoking or using alcohol or illicit drugs. And if you have other illnesses, other inflammatory conditions or comorbidities that need management, then you need to speak to your other specialists as well. In terms of IBD health and IBD medications, we recommend that you see your gastroenterologist to ensure you are in remission, and they will help you confirm that your IBD medications can be continued. One thing of note is that if you are on methotrexate, you need to stop at least 3 months before trying to become pregnant. And so why is it important to have your disease under control in the pre-pregnancy time period? It's important because the disease activity not only affects your fertility, but it can also affect your disease activity during pregnancy. So what I've tried to show here is that if you become pregnant when you have active disease, as shown in the red here, you're more likely to continue to have active disease during pregnancy. On the other hand, if you are in remission at the time that you're trying to become pregnant and conceive, you're more likely to be in remission throughout the pregnancy. And the important thing to realize is that active disease in pregnancy is associated with increased complications such as miscarriage, so early pregnancy loss, stillbirth, preterm birth, and low birth weight babies. And we think this is because when a mother is ill, she has a large inflammatory burden. Her colon and her intestines are inflamed, and she may not be eating well, and so her nutrition may not be as good as if she was in remission. And because the developing fetus requires all of its nutrition from its mother, then that may be explaining why these complications can occur when the mother is not doing well. So how would you know if you had active disease? So there are 3 main ways other than endoscopies or cystoscoping or imaging tests that we can help assess your disease activity. Symptoms obviously is one of the things that you can talk to your gastroenterologist and your physicians about. However, we know that pregnancy symptoms can be confused with IBD symptoms in terms of abdominal cramping and or changes in bowel habit. So what that means is that you may feel well but still have active disease, or you may actually feel unwell but found to have inactive disease, and the symptoms may actually be related to pregnancy. We also will check blood tests. So CRP or C-reactive protein is a common blood test that we will follow for inflammation. However, CRP can be normal even if you have active IBD, and CRP can go up in a healthy pregnancy. And thus, your gastroenterologist may actually ask you to do stool tests. Fecal calprotectin is one of the newer stool tests that is used. It measures an inflammatory protein in the stool. And studies show that fecal calprotectin does not go up in pregnancy, but does go up with active IBD. So although it may be inconvenient to collect stool samples, it's probably one of the better tests to determine whether your disease is active or not. So we do recommend that you follow up with your gastroenterologist and your obstetrician regularly in the preconception and pregnancy time period. And also, if you have symptoms or concerns that you are flaring, then we do recommend that you speak with your gastroenterologist and be seen more frequently than usual. And there will be some times where you will need to coordinate with your gastroenterologist and your obstetrician regarding delivery method and postpartum care. So speaking of delivery, one of a common myth used to be that women with IBD cannot have vaginal deliveries. So we want to reassure you that women with IBD can have a natural vaginal delivery. We generally recommend that you defer the delivery method to the obstetrician because there are more pregnancy-related indications to have a C-section than there are IBD-related. However, we would recommend a C-section in 2 IBD-related conditions, and those are if you have active or complex perianal Crohn's disease, so that's where you have the abscesses or fistulas around the bum, or if you've had that ileal pouch anal anastomosis or that J-pouch surgery that we talked about. And the reason for these 2 conditions to recommend C-section is to protect the anal sphincter, which can sometimes be damaged with a vaginal delivery. And after you've delivered, and now you have a newborn, one of the common questions is whether or not you can breastfeed. So yes, moms with IBD can breastfeed. And it's actually recommended to breastfeed because there's benefits to breastfeeding. There are benefits to your baby in terms of giving them nutrients that are in the milk and some immune proteins as well. And there's some benefits potentially to the mother. As some studies have shown, there's a potential to reduce the postpartum flare risk if a mother is breastfeeding. It's very important, however, that if you are on IBD medications, that you speak with your gastroenterologist about them. And Dr. Seow will talk more about medications specifically. So in summary, we ask you to aim to be in remission before and during pregnancy to give the best outcomes for yourself and your baby. And we recommend that you speak with your family doctor and gastroenterologist before planning pregnancy, so that if you need any further tests or if you need to change medications, that you have time to do so. And please discuss your concerns with your healthcare team. We ask that you do not stop your IBD maintenance medications on your own because there's a risk that you may flare, and it's best to discuss that with your gastroenterologist. So remember that you have a multidisciplinary care team, and that can involve your gastroenterologist, your surgeon if you have one. It can also include your other internists if you have other specialists looking after you, and of course your pharmacist and your family doctor. And we're all here to help you throughout the preconception, pregnancy, delivery, and postpartum time period. So that's the end of my section, and I'd like to hand it over now to Dr. Seow.
Available. So I'm going to present an overview of medication use in pregnancy and inflammatory bowel disease. So these are my sources of support, including research support. And I wanted to start off by telling you and reassuring you that whilst it's really scary to have IBD and to be considering a pregnancy, that both yourself as well as your physician should be well informed about it because it's not an uncommon problem. And I thank the Crohn's and Colitis Canada for their most recent 2018 Impact of IBD in Canada report, which really entails the details about how common IBD is in Canada and what the needs are of our patient groups. And so this is a little quiz. How common is IBD in Canada? And very importantly, it's not uncommon. It affects 1 in 150 Canadians, of which more than 50% are female. So you're not alone in this journey, and there are many people to help you out. So what I really wanted to spend the time today discussing was to dispel many of the myths about medications in pregnancy. And I wanted to provide you some data from around the world about people's concerns. And so this was a Australian study that demonstrated that 19% of women, so that's 1 in 5 women, were concerned about the impact of their disease activity on pregnancy. But the vast majority of patients were actually concerned about the impact of the IBD medications used for disease remission on pregnancy. So in other words, patients were more concerned and more scared of their medications than they were about their disease. And I really want to emphasize that we should be much more concerned about the effects of active disease than we should be about those medications that can keep our disease under control. And in another study, similarly from Europe, 25% of patients reported that they would rather tolerate their symptoms than expose their baby to IBD medications. And so my big question to the community is why? Because the IBD medications, with the exception of methotrexate, are safe during pregnancy and during breastfeeding. And these medications are also safe for males with IBD. And so it's with that knowledge, we should be far less concerned about using medications and really aiming for a healthy mum, which results in a healthy baby. And while many of the mums that come to my clinic say, well, you know what, I would tolerate the symptoms during the pregnancy and all of that, and I say to them, and they say, as long as I have that healthy baby, I'll be okay. I said, I remind them of what Dr. Huang has already told you, that the may be concerning outcomes for both mum as well as the baby. So let's start off when we talk about medications with the biologics, because I think that is the class of drugs that people are most concerned about. And while I do understand that many of the patients or many of you listening in are not on biologics yet, that's a real concern for you guys, that you may require this class of medications in the future. So the biologics are protein molecules, and they include a number of different drugs. Many of these you would have heard of by their trade names: Remicade, Inflectra, Humira, Simponi. They are all what we call anti-TNF agents, so they're all related to each other. But then there are the other 2 newer biologics, which consist of Entyvio and Stelara, which are also big proteins that act slightly differently in the inflammatory cascade. So myth number 1 is biologics need to be stopped during pregnancy. And again, you'll hear this over and over again between Dr. Huang and myself. Be more concerned regarding active disease than active medications, because the risk of disease flare outweighs any risk with treatment. And there was a very elegant study performed in Europe showing that patients who had active disease at time of conception were 7 to 8-fold more likely to flare during the pregnancy. And this is not just uncomfortable for the mum, but can result in adverse outcomes for the baby. So the goal is for mum to be in remission before, during, and after pregnancy. And many of my patients say, well, again, if I can get through the pregnancy, I'll be okay. I said, well, you know what, as a mum myself, it's really difficult if you can't decide once your baby is born whether you're the one that needs to go to the bathroom, whether it's you that needs to go and change the baby's diaper, and whether you're trying to breastfeed your baby all at the same time. So it really is a serious issue that needs consideration. And most of the biologics will be safely continued right up to the 3rd trimester. But the timing of the last dose in pregnancy will be discussed with you. And so this is a little bit dependent on which biologic you are on during that pregnancy. But as I'll show you on the future slides, the biologics are safe for the majority of the pregnancy, and what we really try and tailor is to give you the right amount of the biologic so that we get you through the pregnancy safely, but on the flip side that we don't flood baby with the drug unnecessarily, so that your IBD physician will be able to guide you in that decision. So myth number 1 to dispel is that biologics, in fact, do not need to be stopped during pregnancy. Myth number 2, people are really concerned, well, biologics make my baby look funny. Biologics are actually large structures and they don't cross the placenta in the first trimester when baby is forming. Therefore, biologics do not lead to birth defects. And I tell my patients there are many causes for funny-looking children, but the biologics cannot be necessarily blamed for that because your baby is not seeing, hearing, or smelling this biologic because they are literally not exposed to the biologic during the pregnancy. It does not cross through the placenta during the time that baby is formed. And this goes for any of the biologic molecules, whether they're anti-TNF or the new biologic molecules. They're simply too big to cross over. So myth number 3, biologics will increase baby's risk of infection. And I thought you might like this. This is called the Teddy study out of Europe. And very importantly, apart from its cool name, it demonstrated that there were no significant risks of severe infection in biologic exposed infants. So I know many mums worry that if they're on a biologic that they're at increased risk of infection, and I think the data really shows us that when it's used by itself as a biologic rather than and less so when it's used in combination, that the risk of infection is not significantly increased. However, what was really important from this study is that while they showed that the biologic did not increase the risk of infection, preterm birth, which Dr. Huang has already demonstrated is associated with poor disease control, preterm birth is associated with an increased risk of infection by almost 3-fold. So again, be much more concerned about the risks of active disease than active treatment. Myth number 4, biologic exposure means that my baby can't be vaccinated. And this again is really important. All vaccines can and should be given as per the Canadian Pediatric Society guidelines and your public health office, with the exception of the live rotavirus vaccine, which is given prior to 6 months of age. So depending on which province you're in, most of the live rotavirus vaccines are given at months 2 and 4. There will still be evidence of the drug circulating in baby, even in smaller amounts, but still present in baby to an average of about 6 months of age. And so for that reason, we recommend that the live rotavirus vaccine is not given to the biologic exposed infant. All other vaccines, to reiterate, can and should be given. The next live vaccine that is given in the via the guidelines is the measles, mumps, rubella, and varicella vaccine, and that is only given at 12 months of age. By that time, the biologic has well and truly left the baby's system. So I really recommend that vaccines are given to the baby, with the exception of the live rotavirus vaccine. I'll make a small note here that some of the jurisdictions are offering some form of immune function testing for biologic exposed infants. That has not become mainstream in Canada yet, but if you hear about that, that is an option that is run by specialized pediatric immunization and infectious disease clinics. But by and large, we recommend that you just miss the live rotavirus vaccine. Will that increase the risk of your baby developing a gastrointestinal illness in the future? Well, quite simply, after speaking to the infectious disease doctors, we are fortunate that the majority of Canadian infants are immunized, so there is evidence of what we call herd immunity, meaning that the other babies are not harboring this vaccine. You should also use your usual common sense and do very adequate hand washing, and that prevents the spread of the virus as well. But all other vaccines can be given. So what about other medications? Well, as mentioned first, all IBD medications, with the exception of methotrexate and one of the newer oral agents called tofacitinib, also known as Xeljanz, those are the only two medications that we avoid during pregnancy and breastfeeding. All other medications are deemed safe. And in fact, all these medications are deemed safe in males who are planning to become a father. So let's discuss this in a little bit more detail. Just to finish off the discussion about the biologics with breastfeeding, the molecules are very large, so they only pass in very small amounts in the breast milk. And you have to remember that this is breast milk to the baby's gut transfer. It's not blood to blood transfer. So if you are still breastfeeding at 12 months of age and to the baby will simply digest that molecule in their system. The baby is not being continuously exposed to the drug. So when we talk about the other drugs, what about Imuran, also known as azathioprine or 6-mercaptopurine, pyranethol? In the old days, people were concerned about this drug because it was used at very high doses for the treatment of leukemias and lymphomas. And that's why it got its bad reputation and was designated through the FDA, that's the US categorization of safety of medications, as a category D, meaning that it was considered potentially unsafe. I want to reassure all of you that more recently, we know that the doses that are used in IBD are much smaller, that there is widespread use of azathioprine in IBD patients, in rheumatology patients, in patients with other immune disorders, and transplant patients. And the resounding information has shown that this drug is considered safe during pregnancy, and that there is no need to pump and dump while you are breastfeeding if you are still taking azathioprine or Imuran when you are breastfeeding. So basically, azathioprine and its cousin drug 6-mercaptopurine are safe during pregnancy as well as breastfeeding. People ask about what is the concerns regarding infection if azathioprine is combined with a biologic agent. It does slightly increase the risk of infections, particularly upper respiratory tract infections in the infant. But overall, if your doctor has recommended you to be on combination therapy because they feel that your disease may be harder to treat or harder to keep under control, we still go back to the basic premise that you should be much more concerned about the risks of active disease, which can lead to preterm birth, which in itself increases the risk of infection, as I showed you in the TEDdy study, and you should continue on the medications as listed. There is no concern about fathers using azathioprine and fathering a child. The next category are the 5-amino salicylic acid compounds. You may know these more commonly as pentasa, Salofolk, Azicol, Mezavant. Those are some of the names. Of all of these drugs, these are more commonly prescribed in patients with ulcerative colitis. It's important to know that these drugs can be provided as oral tablets, or they can also be given in the form of rectal therapy as a suppository, which is the little pellet that you insert, or as an enema, which is more of a liquid rectal formulation. Generally, the 5 ASA agents are very safe during pregnancy. There has been a tendency to not use Azicol, which is a certain brand, because it contains a plasticizer in a coating called dibutyl phthalate, which is DBP. However, in the US and other jurisdictions, they are changing to a non-DBP formulation. But if possible, if you can speak to your gastroenterologist or your care provider about the use of non-Azicol products until all the Canadian formulations are changed to non-DBP formulations. If, however, you are already on Azicol and you're already pregnant, it really is not a big concern at all. The studies that looked at Azicol used very high doses in rats, and not in humans. And then they concluded that they would prefer not to use that compound and to use other 5-ASA compounds. So overall, it is a safe medication. The way that 5-ASA agents work is that they basically deposit on the lining of the colon, so they're not really systemically absorbed, meaning that it doesn't really get into your bloodstream that much. It's basically like putting a cream or a lotion on the lining of the bowel. Therefore, there is no concern of using these drugs during pregnancy or during breastfeeding. On that note, I will talk to you a bit more about rectal therapy. People worry about using any form of rectal therapy because they say, well, the rectum is pretty close to the womb or the uterus, and will that precipitate preterm birth? There is no evidence for that whatsoever. The analogy that I often use for patients is that the rectum is the hardest part to treat. So if you are recommended to use a suppository or an enema that's providing extra strength treatment to the area that's most resistant, it's like saying I've got a skin rash and I'm going to put some cream on the area rather than just swallowing the pills, because the cream will provide an extra boost into the area that is most inflamed. So there is no concern about using rectal therapy during pregnancy. Now on to the next class of drugs, corticosteroids. So you know these as probably most commonly as prednisone. And we all know that people are not so keen on using prednisone for a variety of reasons, particularly because of the side effect profile, which we all know can cause things like acne, excess hair growth, excess weight. It can cause a change in patients' mood, which is significant, particularly if you're pregnant when you already got those hormonal fluctuations. And so generally, I classify corticosteroids more as a rescue agent during pregnancy, and I think that sometimes it may hint that a woman's disease was not quite under as optimal control as it could be prior to the pregnancy. So I use it only in the setting of being a rescue agent. It is not a good drug for maintenance therapy, and if you're finding that you're needing steroids like prednisone prior to the pregnancy on a regular basis, then you should be speaking to your provider about being on alternative agents, even if that means an immune suppressant such as azathioprine or a biologic agent, as we've listed before. The reason for this, again, is that the side effect profile for steroids during pregnancy is really significant. Particularly in pregnancy, it increases the risk of other disorders such as high blood pressure or diabetes during the pregnancy, and that is a major concern for the welfare of the baby. The concern is not really about birth defects, although the older literature suggested that there may be a risk of cleft lip or palate. The newer studies have not shown this. The newer studies have really focused on the risks of developing diabetes or hypertension during the pregnancy and causing an adverse outcome that way. Dr. Huang had mentioned about how best to evaluate for disease during pregnancy or even preconception or postpartum, and how a patient can report symptoms. They can also have blood tests. The newer fecal tests or stool tests are really helpful, but in some circumstances, as you know, as an endoscopy or a colonoscopy is necessary. Generally, we do not do routine colonoscopies during pregnancy at all. We would only do this if there was a real concern about the disease activity and trying to make a decision about the medication. But you should not be worried about the bowel prep and the sedatives if it's really necessary during pregnancy, if it's going to change your management and is recommended by a doctor. And particularly, you should not be concerned about having a colonoscopy or sigmoidoscopy in the postpartum period, even if you are still breastfeeding. If you're having the scope during pregnancy, you will be advised about your doctor about the risks and the benefits of the procedure, and minimal sedation or a safe amount of sedation will be used. The main concern for breastfeeding women when it comes to having colonoscopy is regarding dehydration from the bowel prep. The bowel preparation, as you know, gives you the runs. That's what it's intended to do. It is not absorbed, so it will not affect the baby. It does not pass in the breast milk, but it makes patients dehydrated, and that may impact on the milk supply. So I generally tell patients to keep up a lot of fluids if they need to have a scope while they are still breastfeeding. As for the risks of sedatives, if you are still breastfeeding, quite simply, there is no real need to keep pumping and dumping the breast milk. If you are, in inverted commas, sober enough to hold baby post-procedure, then you can, and you are sober enough to hold baby without dropping baby, then you probably can resume breastfeeding at that time. To put it fairly crudely, both the breast as well as the brain have a high concentration of fat. So when the drug has left the brain and you have recovered and are now sober, you are then able to resume breastfeeding. And so I think that's a major point, because many patients we find try and delay their colonoscopies till they're finished weaning off their babies and will suffer the effects of active disease and inadequate treatment because they're worried about the colonoscopy. Again, healthy mum equals healthy baby. So to summarize my section, and some of Vivian's as well, 5 things to know about IBD and pregnancy. When you're thinking about pregnancy, you shouldn't be scared. I hope I've demonstrated that IBD and pregnancy is a common clinical scenario. When you're truly in the preconception phase, remember that pregnancy outcomes in IBD can be modified, and that if you get your disease under control, that you will do well. During the pregnancy, remind yourself yet again that you should be more concerned about the risks of uncontrolled disease than the medications used to control the disease. When you are delivering, remember that the mode of delivery should generally be determined by obstetric indications rather than GI indications, with the exception of having active perianal disease or if you have the ileoanal pouch procedure. And postpartum, we recommend that you don't administer live vaccines in anti-TNF or other biologic exposed infants prior to 12 months. Meaning, again, that you would miss the live rotavirus vaccine, but all other vaccines can and should be given. And so in conclusion, happy mum equals happy baby, and your next challenge should be dealing with children. And for those of you who are already mums or are planning to be one, then these syndromes will become more of a concern to you than your IBD during the pregnancy. And we wish you all the very best for your pregnancy, and are happy to answer any questions.
Great. Wow. Thank you so much, Dr. Wong and Dr. Seow, for your thoughtful and informative presentation. You covered a lot of really important topics and addressed some of the questions that came up either pre-presentation or during the presentation, but we're going to move on to the Q&A section. We did receive quite a number of other great questions that we're going to address. So if you just let me go through them in no particular order. So the first question, I'll direct this to Dr. Wong, but Dr. Seow, please feel free to respond as well. The question is, can active IBD disease increase a mother's risk of preeclampsia or postpartum eclampsia?
There is some associated risk in some of the research that when you have active inflammation of any sort, so not just IBD, that it can increase cardiovascular, so including like vascular supply to the placenta. So it's not a huge risk, but it has been reported. But preeclampsia can occur for other reasons as well, like other than IBD. So the best way to watch out for that, I guess, is to ask your gastroenterologist and your like family doctor or whoever is looking after you early in pregnancy if to get a referral to one of the higher risk or special pregnancy programs, of which there are several clinics around Canada. And they can usually do an assessment and assess the placental health as well.
Okay, great. Thank you so much. Dr. Seow, I have a question for you. This question was actually around IVF medications and whether the actual medications that a patient might be given for IVF can actually impact negatively their IBD disease in any way.
So it is true that the IVF medications do include often a hormonal preparation, but in general, if the IBD is well under control, then those risks are minimized. And in fact, I have there are even publications where drugs, including Humira, have been used as a pro-fertility agent in some of these IVF clinics. So that really demonstrates two things. One, that the drugs that we use in IBD are safe if they're being used by the fertility doctors. And then the second point, again, is to ensure that the disease is well under control, particularly before embarking on assisted reproductive therapies. Those kind of therapies, as we all know, are huge emotional, social, and financial. They can be quite a stress from that point of view. So if you're going to engage in that, then really ensure that you give yourself the best chance by getting your disease under control. And we do communicate regularly with the fertility clinics about what they're doing and what we are doing. So it's a joint decision.
Okay, great. So that's very helpful. Dr. Wang, we had earlier in your presentation, you talked about 2/3 of pregnant women will most likely stay with inactive disease. But for that 1 out of 3 women who may be in remission but flare during pregnancy, what are some of the concerns that they should be aware of? What would you recommend that they do in terms of if they feel like they are having a flare, and sort of how do you determine whether that's pregnancy related or whether it's IBD related?
Yeah, so that's a great question. So actually, one of the most common reasons probably that people flare is because they stop their medications.
Mm-hmm.
So definitely to try to prevent flaring is if you're on a stable medication that you've discussed with your gastroenterologist, and is one of the ones, as Dr. Seow had listed, most of them are safe and can be continued, then please don't stop unless it's been advised regarding timing around delivery, etc. However, there are still some people who will flare even when they're on medications. So if you develop any new symptoms and you're not sure, are those abdominal cramps pregnancy related or IBD flare related, then it's best definitely to call your gastroenterologist and just they know you should tell them that you're pregnant, first of all, if you haven't, but they can investigate, rule out infections, because it's so pregnancy and IBD puts a person at higher risk for one of the bowel infections, so a Clostridium difficile or C. diff.
Mm-hmm.
So they definitely need to get their stools checked for infection, because the treatment's different. If they're found to have C. diff infection, it's actually an antibiotic treatment. But if they don't have any kind of infection and it's actually the IBD is flaring based on investigations, they may need adjustment in their medications. So our recommendation in general is don't hesitate to call your gastroenterologist. We're here to help. Just call into the clinic if you're concerned at all.
Okay, thank you. And sort of somewhat related to that, we had someone ask, can severe diarrhea increase the risk of miscarriage?
So it would depend if the diarrhea, if the person is getting dehydrated, for example, or malnourished, then yes, and if it's because of active disease or ongoing infection, it can increase the risk of miscarriage because the mother is sick. And as Dr. Seow was saying, a healthy mom is a higher likelihood of healthy baby. So if the mom is sick, having profuse diarrhea, getting dehydrated, getting malnourished, lots of inflammation, there is a higher chance of miscarriage.
Okay, thank you. Dr. Seow, there's been a number of questions around sort of nutrients for mothers. We know that folic acid is really important for women becoming pregnant.
Mm-hmm.
Are there any additional nutritional deficiencies or things like that women with IBD should be aware of, either before becoming pregnant or during their pregnancy?
Yeah, I generally check all my patients for vitamin D, which we know is reduced often in patients, in any person living in Canada. And we recently published that there is a significant risk of vitamin D insufficiency in Canadian women. So I check for vitamin D, vitamin B12, and iron are the main three folate and all of these other micronutrients are provided in a standard multivitamin, but you should ask your gastroenterologist if additional vitamin D, B12, or iron are required. And we know that babies are very clever. They will use up the mum's iron supply to form their own blood cells. So if you can get the iron levels at a good steady level prior to the pregnancy, that would really help out the mum as well, because when patients are iron deficient, they're more likely to get quite tired as well. So minimum of a multivitamin plus or minus further supplementation of vitamin D, B12, and iron.
And what about folic acid? Would you recommend a higher dose for women with IBD?
I would say that the amount that is provided in the multivitamin is usually sufficient, because most Canadian women do get adequate folic acid from other sources. The only exception is if the woman is, it's less common now, is on something like sulfasalazine, then we recommend that 2 grams of folic acid, or megadoses of folic acid are required. But sulfasalazine is not used as commonly as the other 5-amino salicylic acid compounds, because it's not as well tolerated in general.
Okay, great. Thank you. This is a question for Dr. Wang. You had mentioned that C-sections were recommended for women who have active rectal disease, including fistulas. What if an individual has had past fistulas that are present but not active? Would it still be recommended to have a C-section birth?
In that situation, in talking to our colorectal surgeons and our obstetricians, it would depend on whether it's healed, like if it's healed up, or if it's still present and active and could cause complications. Okay. And they had also indicated that it may depend on where the fistula is and how complex it is. If it's in the front, so close to the vagina area, then there's more likelihood that it could get you could get tearing or damage and poor wound healing. But our colorectal surgeons and obstetricians have actually said that if it's a simple fistula that's on the back side, then maybe it may not indicate that they have to have a C-section. The best recommendation that I would give is that you need to see your obstetrician and your colorectal surgeon, because it's an individual decision based on the woman's disease and where it's located and the complexity.
Okay, great. Thank you. I have another question for you, and this might be sort of one of those myths that arises, or maybe it's not a myth, maybe you can dispel this or not, is it possible that becoming pregnant can actually lead to disease remission or reduced IBD symptoms during pregnancy only?
So it's not really a myth. It's kind of in that in one of my slides, I think I tried to emphasize that people who have active disease, there are a small proportion who actually go into remission. It's just that we don't really have a way to predict which women that would be. So that's why we always recommend to try to get everybody into remission first, so that they can stay in remission. And the exact reason for that is still being researched. A lot of the studies are looking into it, and maybe it have to do with the hormone, like the changes in hormones in pregnancy. For some women, might help their disease go into remission, whereas in other women it doesn't. So there are some women who do seem to get better during pregnancy.
Okay,
but
great.
This is not the best time to try out whether the
that's not a
medications would be a good idea.
Yeah.
No.
Yeah.
We wouldn't recommend it as a treatment.
Go into remission. No. Okay. This is a question for either of you. I guess I'll direct it to Dr. Seow. Is recovery from C-section different for women with IBD than women without IBD?
No, it shouldn't be at all. And one of the points that I didn't elaborate before is that even if you are on a biologic agent, even if there is sometimes some changes in the dosing during the last or the third trimester, but once baby is born, I always give my patients the motto, baby out, drug in. So for the most part, patients who are on a biologic can be given the biologic agent immediately postpartum before they leave the hospital. It's much more convenient for a mum than dragging in a newborn baby to an infusion center. And even if the mum has had a C-section, the mum can still receive the biologic agent as long as they haven't had a significant complication from the C-section prior to leaving the hospital. The only other caveat is that the patients with C-sections often are given antibiotics. So if the mum develops worsening diarrhea after the C-section, as Dr. Huang mentioned, these women should be checked for C. difficile, which is an infection that's more common in people who have been exposed to antibiotics. But overall, the recovery from a C-section is no different in an IBD versus a non-IBD woman.
Okay, thank you. I'm noticing the time. Maybe we'll try and get to just one or two more questions. Just looking through the list. We had a question about exercise during pregnancy. Are there any extra precautions that women with IBD should take in terms of approaching exercise when they're pregnant?
No. Yeah, it's most important, just even for a healthy non-IBD mum, to keep up, some form of physical activity. Of course, not strenuous during the pregnancy, but exactly the same recommendations. Ultimately, the pregnancy shouldn't be seen as a disease that's preventing you from doing things, and the IBD should not be considered as an additional burden if the disease is already kept under control. So, mums should. IBD mums, along with normal mums, should try and enjoy their pregnancy as best they can.
Okay, great, thank you. Yeah, I'm just looking, and I think we covered most of the questions that were asked. So thank you so much to both of you for taking the time out this evening and educating the community. As we're drawing near the end, I just wanted to remind everyone that we'll be following up with you after the webinar via email to get your feedback and any suggestions you have for future education programs and topics. And we'll also be sending a link to a recording of tonight's webinar. So if by any chance you missed the beginning or wanted to view it again, that will be sent to you within a few days. Also wanted to remind everyone, this is our last webinar for the calendar year 2018. However, this is just one of many online education initiatives that Crohn's and Colitis Canada provides. So stay tuned for upcoming education events in the new year, 2019. For more information, you can check out our website at crohnsandcolitis.ca/learn, and our social media is at GetGutsy. Right. Finally, we also wanted to invite you to get involved in IBD research. If you are interested in learning more about Crohn's and Colitis Canada funded research, please visit our website. And if you want to get involved in research, go to participate in research section to find out more about how you can get involved. Finally, we invite you to make more discoveries and breakthroughs possible. Now in its 24th year, Gutsy Walk has raised over $38 million for research, advocacy, and patient programs, and we'd like you to be a part of it. With your support, cures for IBD are just steps away. Register now at gutsywalk.ca and join us on Sunday, June 2nd at a location near you. Thank you everyone for joining us this evening and for your thoughtful questions, and I especially want to thank our speakers for this evening, Dr. Vivian Wong and Dr. Cynthia Seow. Thanks for taking time out of your schedules.
Thank you.
And thanks for sharing your expertise with us. We'll also be using some of the education from this webinar this evening to contribute to our other online learning, so whether it's through our brochures and our website content. So thank you for being a part of that and for sharing your expertise with us. Once again, if anyone has any questions following up, please write to us at learn@crohnsandcolitis.ca, and we would be happy to follow up with you directly. And this concludes tonight's webinar. Thank you again for your participation, and have a good evening, everyone.
Thank you.
Thank you.
Thank you.